And, you know, in the UK, where I practice as a pharmacist, sodium valproate is contraindicated in women of childbearing age unless there's a pregnancy prevention program in place. And all healthcare professionals must continue to identify and to review patients on valproate, including, you know, when it is used outside of, you know, licensed indication. You know, sometimes sodium valproate is used for as a mood stabilizer, and all healthcare professionals have the responsibility to make sure that the patient is aware of the risk, you know. So when the sodium valproate is started for epilepsy, it is only started if there's no other drug, you know, that they can use. They've tried carbamazepine, they've tried phenobarbital, they've tried and all those drugs are not working. Then they would choose sodium valproate in a women of childbearing age potential. And I think, you know, this is from the age of 12 to 50. And so without trying other drugs, a woman would not be started on sodium valproate in the UK. And also a pharmacist, as a pharmacist, I would have, when I'm dispensing or when I'm giving out sodium valproate to a woman of childbearing age, it is my responsibility to check that they have got a risk assessment form in their medical notes that is stating why they are on sodium valproate and if they've tried any other anti-epileptic medicine. So, in being in conversations with doctors and healthcare professionals, and also people at the foundation here in Zimbabwe, one of the things that they highlighted is the lack of, anti-epileptic drugs, the lack of choice in here in this part of the world, therefore which forces the doctors and the patients to go for sodium valproate or to go for the more traditional, the older anti-epileptic drugs. But I just thought this is a good opportunity to remind everyone about the risks of anti-epileptic drugs in women of childbearing potential if they were to get pregnant. And so, not just to say do not prescribe this drug, but more from a point of when we are starting these medications in women, are we having a conversation with them, telling them about the risks? Are we telling them are we giving them option? I really like what the previous doctor said, and he was talking about shared decision making. Is there really a shared decision making in our patient cohort in Africa? And do they know that, they've got that they can discuss with their doctor? When he was talking about the burden of epilepsy as well, most of the people that are affected at the bottom of society. So sometimes they find it difficult to discuss their options with doctors. But I just wanted to encourage healthcare workers, to give them the opportunity to really make it a shared decision. When you're starting a new drug, are you explaining, this is what it's used for? These are the side effects. If you're planning to get pregnant, I want you to know about this risk. And the patient really makes the decision if they want a child or if they want to stay on that drug. So this is just, in Zimbabwe, this is just a rough estimate of the drugs that are available and the risks that physical birth abnormalities and neurodevelopment disorders. So I think lamotrigine is one of the drugs that are recommended in women of childbearing age. However, the cost is quite high. And in Zimbabwe, it's about $52 a month. If a patient is on a maintenance dose of 200 milligrams, and the risk of physical birth abnormality is the same as the general population, 2 out of 3 babies out of 100, 2 or 3 babies out of 100. But when you compare it to sodium valproate, which is 10 out of 100 babies, and approximately 30 to 40% of these children will have neurodevelopment orders, the difference is about $10. I understand that $10 to somebody who does not have that risk that cost is too high. But then when we then start to think about what is the cost of raising a child who's physically disabled, what is the cost of raising a child who has neurodevelopment orders, surely $120 a year is a cost that maybe policymakers here, maybe government officials here, maybe people who write, essential drug lists who are here should start considering, like, what do we really mean when we say cost effective? Is $120 a year a cost saving per patient, a cost saving that we are all happy? We're saying, as a person who's writing guidelines, we are happy to say that, $120 is too high a cost per patient. We would rather have a disabled child, or would rather have a child with neurodevelopment disorders. That is, my opinion, and, the way I would look at it. So it is really up to the government officials, it's really up to policymakers, it's really up to, doctors who write these guidelines. When we are considering costs and when we are speaking to a patient, are we really giving them options to say this is what's on the table? And or maybe we can also give them choice to say, maybe we can start carbamazepine, it is significantly cheaper, or phenobarbital, it is significantly cheaper, but the risk is also slightly lower. So looking at all this, I just wanted to sensitize everyone to the risk of sodium valproate and say, 10 out of 100, baby, 1 in 10 is too big a number to not talk about it. Or 30 to 40% of children who have neurodevelopment orders is too big a number for us to be comfortable with, and for us to not tell the patient about this risk. So that is all from me. I just wanted to bring this to everyone here and say, when we go back to our epilepsy support foundations, to our government, can we really push this initiative? Here in Zimbabwe, we've already started the conversation with the regulatory agency, and they're quite engaging and are happy to remind the doctors and the healthcare professionals, and also send patient information leaflets to the healthcare workers to remind them of the risk, and also remind them of the importance of shared decision making with the patient. Thank you very much.
You're welcome, Rumbi, and thank you very much.